Assalamualaikum and good day. I'm Dr. Mardiana and I will be delivering part 2 of the lecture diseases of the vulva, vagina, cervix and uterus. So for part 2 of this lecture, we will focus on the risk factors, pathogenesis, morphology, and clinical effects and complications of endometrial carcinoma and leiomyoma, and correspondingly we will focus on the skills of identifying the morphology of endometrial carcinoma and its preneoplastic lesion, as well as uterine leiomyoma. So I would like to start just by listing some of the causes of abnormal bleeding, because abnormal bleeding is one of the commonest ways of presentation of any problems arising from the uterus or the endometrial cavity. As you can see that it is quite a long list, and it covers everything from an endocrine abnormality or endocrine disorders, or could also be organic lesions such as tumors, can be inflammatory in cause. So it's really quite diverse, but for today's lecture we're going to focus on endometrial hyperplasia in cancer as well as leiomyoma. So let's start with endometrial carcinoma and its precursor lesions. Endometrial carcinoma can be divided into two parts, simply called endometrial carcinoma type 1 and endometrial carcinoma type 2. They are actually different in the sense that both of them have different pre-invasive or precursor lesions. So for endometrial carcinoma type 1, the precursor lesion is endometrial hyperplasia, whereas for endometrial carcinoma type 2, it is intraepithelial carcinoma. So if we look, first of all, at the endometrial carcinoma type 1, the risk factors that are associated with development of this type of cancer is really relating to unopposed estrogen, because that is a known pathogenic mechanism in the formation of endometrial hyperplasia. So as such, we will go through this one by one in a moment. Whereas for endometrial type 2 carcinoma, these are often arising in the setting of endometrial atrophy, where patients can develop intraepithelial carcinoma, which then progresses to endometrial carcinoma type 2. So what is endometrial hyperplasia? Endometrial hyperplasia simply refers to the state where you have an increased in-gland to stroma ratio within the endometrium. Simply put, you have more glands or too many glands compared to the stroma. As you know, endometrial proliferation is estrogen dependent. So the main pathogenesis of endometrial hyperplasia is unopposed estrogen, meaning you have too much estrogen and not enough progesterone to counter its effect. Recall the normal menstrual cycle in a female. We know that estrogen drives proliferative activity within the proliferative phase, and in normal setting, after ovulation, the corpus luteum becomes the main source of progestogen or progesterone, and progesterone basically has the action that opposes the action of the estrogen, and that allows sort of balance occurring physiologically, and you get subsequent secretory changes, and then they go into the menstrual phase, and then the cycle begins again. In the event where you have too much estrogen and not enough progesterone to counter its effect, or states where you just don't have or there are states where the progesterone is just not produced, then you get the net effect of excessive proliferative activity, and this gives rise to the hyperplasia that you see in this setting. So knowing that endometrial hyperplasia arises in the setting of unopposed estrogen, we can discuss the risk factors for endometrial hyperplasia along the lines of conditions that lead to excess or unopposed estrogen. So where does this estrogen come from? The sources of estrogen in this setting can be either endogenous, okay, so endogenous sources coming from inside the body, or exogenous sources. So we'll start with discussing examples of endogenous sources of estrogen. The first one is actually an ovulation. Okay, so anovulatory states mean that there will be no corpus luteum developing, and therefore there will be no progesterone being produced. So whatever estrogen that is present in the body is now unopposed. The second source of endogenous estrogen is actually obesity. So obesity leads to peripheral conversion of androgens to estrogens by the enzyme aromatase in fat cells, right? So this becomes a source of excess estrogen. The third condition associated with increase in endogenous estrogen is actually PCOS. PCOS is short for polycystic ovarian syndrome. PCOS can lead to the state of excess of unopposed estrogen probably via two main mechanisms. Number one, patients with PCOS tend to not ovulate. So this chronic anovulatory state can produce excess estrogen, as I've mentioned earlier. And secondly, patients with PCOS also tend to be obese, right? So they share the same mechanism as I have mentioned earlier as well. So in addition, there are two other conditions affecting the ovaries, which are functioning granulosa cell tumors of the ovary, as well as cortical stromal hyperplasia. These can actually be the source of endogenous estrogen because they, or the cells in these conditions, can produce estrogen. Alright, so what about exogenous source of estrogen? The most common one, or basically exogenous means that it's coming from outside. So the source of that will be any prolonged exogenous estrogen therapy. The most common is probably hormonal replacement therapy in the postmenopausal state. And another possible source is OCP, oral contraceptive pill, which is estrogen only preparation, but that is rather uncommon this day and age. Okay, now let's discuss the morphology of endometrial hyperplasia. Endometrial hyperplasia can be divided into endometrial hyperplasia without atypia and endometrial hyperplasia with atypia. And the distinction relies on the presence or absence of cytological atypia. So as the name implies, endometrial hyperplasia without atypia means that the cells that are present within that hyperplastic process shows no cytological atypia, whereas cytological atypia is present in the other group. Often they have differing architecture as well. In endometrial hyperplasia without atypia, the architecture of the glands are often simple and tubular. And what does simple and tubular mean? Simple and tubular means that they are well-rounded, okay, and well-circumscribed. Whereas a complex architecture is often seen in endometrial hyperplasia with atypia, and complex means they start to branch, okay, they may look like a flower or a starfish, and that is often seen in this setting, but not in the one without atypia. Okay, and why do we divide endometrial hyperplasia this way? It's really because they have different behavior. Endometrial hyperplasia without atypia has a low risk of progression to carcinoma, only between 1 to 3%, whereas endometrial hyperplasia with atypia has a much higher risk of progression, around 20 to 30% of the cases. So what do they look like under the microscope? So let's first look at the normal endometrium. So this is normal endometrium here. I just pointed out to you, so you can see that the glands are nice and tubular and rather straight. There's a good gap in between one gland to another, and this is a stroma in between. So this is a normal gland to stromal ratio. So when we look at endometrial hyperplasia without atypia, so first of all, because the name is endometrial hyperplasia, hyperplasia, and by definition endometrial hyperplasia means you have more glands, so increase in gland to stroma ratio. You can immediately compare this one to the normal endometrium, and you can see that there is an increase in the number of glands within the stroma. But another striking thing is that the tubules are quite similar to normal endometrium in that they are nice and tubular and straight, and the cells are still relatively small. So this is what we mean by simple tubular architecture, and the cells being small and fairly regular means there is no cytological atypia. So now we compare that to endometrial hyperplasia with atypia. So immediately you can see that the glands are much more complex. So this is the complex architecture I was referring to. So it's no longer nice and rounded and straight, but rather you can see that it started to branch. It looks a bit like a flower or a starfish, whatever you want to call it, but it's just quite complex and crowded. And on higher power examination, we can see that the cells are much larger. It has large atypical nuclei, and some probably even start to acquire nucleoli, and you can see mitosis. So these are all markers of cytological atypia. So we've discussed endometrial hyperplasia in terms of the risk factors, in terms of the pathogenesis of unopposed estrogen, and how it leads to the formation of endometrial hyperplasia. So endometrial hyperplasia can then progress to form endometrial carcinoma type 1, as we have mentioned earlier, and this progression from hyperplasia to carcinoma occurs in the setting of the presence of atypia, so endometrial hyperplasia with atypia, and also with accumulation of multiple genetic abnormalities, especially those affecting the PIK3 AKT signaling pathway. Of these, the P10 mutation is the most common, and also that affecting the DNA mismatch repair genes. So that actually completes the pathogenesis of endometrial carcinoma, which arises in the setting of endometrial hyperplasia. In contrast, in terms of pathogenesis of endometrial carcinoma type 2, the only thing that I want to mention, and the only thing that you need to know at this point in time, is that it has a different genetic mutation, underlying genetic mutation that is common in type 2 carcinoma is TP53, which accounts for about 90% of the formation of its tumor. This table summarizes the main features and differences between type 1 and type 2 endometrial carcinoma. So as you can see that the characteristics in terms of the age and clinical setting, the morphology, precursor, genetic abnormalities and behavior, there is some differences between these two groups. Type 1 essentially occurs in a slightly younger age group compared to type 2. They arise in a different clinical setting, as we've discussed, because type 1 arises in the setting of unopposed estrogen and endometrial hyperplasia. Thus, the setting is slightly different to type 2. The morphology is also different. For type 1, the cancer is endometrioid, which means that it resembles the normal endometrium, and that reflects the lower grade of the tumor you see in type 1, whereas type 2 has a much more high grade morphology, typically either serous or clear cell, and this is similar to that seen in the ovarian tumors. The genetic abnormalities are also different, as we mentioned in the last slide, and the behavior is practically indolent in type 1, and it's quite aggressive in type 2. So let's have a look at the morphology of endometrial carcinoma. Endometrial carcinoma obviously arises from the endometrial lining of the uterus. The morphology can be quite diverse. It can form a small tumor, let's say for example here in the fundus of the uterus, but the rest of the endometrial lining looks okay, or it can actually occupy or extend on the entire surface of the endometrial cavity, like this one, forming multiple projections into the lumen, or occasionally in advanced cases it can actually form a large mass which occupy and distends the uterine cavity. The microscopic morphology depends on whether you are dealing with a type 1 carcinoma or type 2 carcinoma. In type 1 carcinoma, because they are endometrioid in nature, they tend to resemble the normal endometrium to a certain degree. So the malignant glands are arranged as complex architecture. They infiltrate the stroma and the myometrium. They can have nuclear atypia. And the thing about endometrial carcinoma is quite a proportion of them will have squamous differentiation, but this does not affect the grade or behavior of the tumor. For type 2 carcinoma, this is typically of serous type, so they tend to have papillary architecture. The cytologic atypia is often extreme with nuclear pleomorphism, hyperchromasia, and high NC ratio, as well as numerous mitosis. So as you can see here, you have a papillary projection with this luminal proliferation and cells projecting into the glandular lumen. The most common clinical manifestations of endometrial carcinoma is in the form of abnormal bleeding, and this is also a manifestation of endometrial hyperplasia. Patients can have irregular menses or menorrhagia if premenopausal, and if the woman is postmenopausal, then they can have postmenopausal bleeding. In the setting where the uterine or endometrial carcinoma is advanced, like the one that we saw earlier in the gross image, then uterine enlargement, which may be palpable, can also be seen, and occasionally patients present with features of advanced spread to other sites away from the uterus. So that brings us to the topic of the spread of the cancer. As you know, cancer can spread through direct spread to adjacent organ, or they can have lymphatic spread to regional lymph nodes, or occasionally they can also have hematogenous spread into distant sites and organs, such as into the lungs, the liver, bones, and also other organs in the body. For endometrial carcinoma, the direct spread usually means that the cancer goes into myometrium, into the deep myometrium. They can also go down into the cervix, okay, adjacent organ into the cervix. They go sideways into broad ligaments, and we discussed lymphatic and hematogenous earlier. Another interesting way of spread of cancer in endometrial carcinoma is transtubal spread. But this applies only to type 2 carcinoma because serous epithelial tumors can exfoliate, so they fall off into the uterine cavity, endometrial cavity, and then the malignant cells travel through the fallopian tube out through the fimbrial end, and they can implant on peritoneal surfaces. So this is one unique way of type 2 carcinoma spread, which also explains why a lot of times when type 2 carcinoma is discovered, they are already advanced and they may have numerous peritoneal implants. Next, we will talk about another common tumor occurring within the uterus, which is leiomyoma, or also known in layman's term as fibroids. This is very common. It is a benign smooth muscle neoplasm arising from the myometrial wall. And they can be single or they can be multiple, like you can see in this image here, which has significantly distorted and caused enlargement of the uterus. What about the morphology of the uterine leiomyoma? They have several characteristic features. They're often well circumscribed, so you can see that they're well rounded. You can draw a line surrounding them. They are round, they have gray-white color when you cut through them. The size can vary. Some of them can be small, but some can grow to really large proportion. And also another feature is when you cut into them, you can see a whorled cut face. So it's like a swirling appearance on the cut face. The leiomyoma can take several locations, and here we shown in this image is actually 3 typical locations of the leiomyoma. They can be intramural, okay, which is this one here, located within the wall of the uterus. So you know this is the endometrial cavity, this is the myometrial wall, and this is the serosa on the outer surface. They can also project outwards, okay, so we call that subserosal when they project outwards, and they can project inside into the endometrial cavity, and we call that submucosal in location. Next, we move on to microscopic morphology of fibroids. So as you can see here shown in this image, the tumor is formed by spindle cells, similar to normal myometrium because that's what they arise from, and they are benign, so they are uniform with no atypia. They are arranged in fascicles or bundles, so you can see several of these cells are streamed along the same way, and they intersect with each other. So one fascicle go that way, another fascicle go this way. So that explains the whorled cut face that you see on gross examination of the leiomyoma. And another feature is that they will lack mitosis typically because this is a benign tumor with very low proliferative activity. Clinical effects and complications of leiomyoma depend somewhat on their size, depend on their number, and depend on their location. So it can produce some mass effect such as urinary frequency if there is compression of the bladder. There can be some pain. The patient can present with some pain, especially if the tumor grows to a large size and there is infarction within the tumor. As you can see shown in this image here, sometimes the leiomyoma can significantly distort the shape of the uterus, and in addition, if you have a submucosal leiomyoma, it can also occupy the uterine cavity as seen here. So these combination of distortion of the uterine shape and also occupation of the uterine cavity can produce abnormal uterine bleeding such as menorrhagia, or patients can also present with impaired fertility due to failure of implantation. In addition to that, there are a few pregnancy-related complications, again explained by the distortion of the uterus and also the fact that the myoma can occupy the uterine cavity. Patients can have problems in terms of recurrent spontaneous abortions and miscarriages because the fetus cannot grow normally because there's no space. Secondly, patients can also present with fetal malpresentation, i.e. failure of inversion, because you know that normal birth, the head should go down, but during early pregnancy the head is still up here, so the fetus inverts close to delivery, but that can fail to happen because the myoma has occupied the uterine cavity. And lastly, during birth and after birth, it could be problem with contraction of the uterus, and patient can have postpartum hemorrhage as a complication. Of course, a subset of patients are actually asymptomatic, especially if the uterine fibroids are small. Okay, so before we end part 2 of this lecture, I would like to just have a quick recap of what we have covered this time. So we have talked about endometrial carcinoma being of 2 types, type 1 and type 2, and we have discussed especially in detail pathogenesis of type 1 endometrial carcinoma, which begins with the presence of the states of unopposed estrogen with its related risk factors leading to formation of endometrial hyperplasia. But we now know that endometrial hyperplasia can be with or without atypia, and without atypia has a low progression to cancer. So in order for progression to cancer to happen, typically this occurs in the setting of endometrial hyperplasia with atypia and also in the presence of acquisition of various genetic mutations, especially that involving the PTEN gene. In contrast, for endometrial carcinoma type 2, it has a completely different genetic mutation underlying its pathogenesis. Typically, it involves a TP53 mutation. We have also discussed the morphology, the clinical complications of endometrial hyperplasia, endometrial carcinoma type 1 and type 2, and we have also compared the 2 types of carcinoma in the table that we have shown or we have discussed earlier. A quick recap of leiomyoma. This is a very common benign smooth muscle tumor of the uterus. Typically grossly has a well circumscribed appearance, homogeneous cream and whorled cut face. no necrosis, no hemorrhage, and histologically characterized by intersecting fascicles of smooth muscles without atypia. And the clinical manifestations are dependent on the number, the size, and the location of the leiomyoma. So that marks the end of part 2 of this lecture. And the references that I used were Robbins and Cochrane, Pathologic Basis of Disease, the 9th edition, and also the Robbins Basic Pathology, 10th edition. Thank you.